right, let me get my slides in slide presenter mode. Again, welcome everybody. I'm so glad that you were able to join me today to talk about medications for opioid use disorder and talking with clients, families, and colleagues about facts versus fiction. This is hosted by the University of Minnesota Extension, and I want to acknowledge our Great Lakes Rural Opioid Technical Assistance Regional Center, funded by SAMHSA, that has allowed for this to happen today. So um, kudos and thanks to them. Always just want to remind folks that we really want to use person first language when we're talking about health and behavioral health. So please, if you hear me say anything that might be received poorly, or call me out, let me know. I want to learn too. You can either do that in this forum or you can shoot me an email afterwards. So we'll try to be mindful of our words. All right. My name is Keri. I am a faculty member, professor, and associate dean at the University of Minnesota, based out of our beautiful Duluth campus at the tip of Lake Superior, for folks that maybe aren't familiar, one of our Great Lakes. And then I get to practice as part of my job. I get to practice down at our Center for Alcohol and Drug Treatment in Duluth 2 mornings a week. And in that role, I meet with people one-to-one to help work with them and their care team to optimize their medications and outcomes, make sure, they're only taking what they need, not having side effects, drug interactions, and then trying to get those tuned up to help them in their recovery as well. If you haven't introduced yourself and you'd be willing to, love to know who you are and where you're joining from in the chat. So please feel free to do that throughout. I want to acknowledge there are a lot of colleagues that have contributed to this presentation over the years. We've been modifying it and updating it with tips and ideas that people have had. And as language has changed, we already talked about the funding to support this. And I just really want to acknowledge all of you for showing up today and making the time to participate in the conversation and hopefully learn something useful in whatever realm you work or practice. So we'll do the presentation and then have Q&A. There's some polling throughout to engage our audience, but please feel free to chat in questions and things along the way, and I'll get to them as we go. And then certainly at the end, we'll have some time as well to connect. I really want to make this useful for you. So if there's stuff that is on our agenda that, or is not on the agenda, but you have questions about, if we don't get to it today, we can definitely connect afterwards. And I'm happy to meet with you or talk with you or email with you, whatever is useful. So before we get started, and we'll just do this in the chat if you're comfortable. If you're not, you can just think about it in your head. But thinking about, where are we? So when you think about your own understanding of medications for opioid use disorder, for example, methadone or buprenorphine, which is like the Suboxone is a brand name product. When you think about your own understanding, is it complete? Are you teaching other people about this? Do you know a fair amount, but you have more to learn? You don't really know much, that's why you showed up today, or you think it's just terrible and everything you know about it is bad. So I'll give you a few moments here to chat in. Welcome to folks who have just joined us. Thank you. We're glad you're here. All right. So I'm seeing in the chat some B's and C's. So a fair amount, some and some not so much. So that's great. Hopefully, even if you know a lot about it, that maybe you'll get a nugget that's helpful for you in your work today. Or maybe you can share something new with the rest of us that we can use to improve what we do for folks in our community. So our goals are really to talk about meds for opioid use disorder. You may hear MOUD, MAT, medication-assisted treatment. Kind of these terms are being used interchangeably, but we're really, the language has moved to medications for opioid use disorder, just like medications for high blood pressure or diabetes, to try to destigmatize that. I'm going to summarize the research supporting the use for these medications, talk about stigma that prevent adequate treatment. And then really my goal is for you to leave with some new ideas about how to talk to clients, families, colleagues, whoever in your circles around medications for opioid use disorder, and be equipped with information that you can share that is accurate and help you dispel some of the myths that may be out there. If there are other goals you have, please feel free to chat them in. I'm going to switch on over and start out with a patient interview video. This is a 6-minute video of one of my colleague physicians interviewing a patient she is working with, who takes, she says, Suboxone, which is the buprenorphine product for opioid use disorder. and how that has impacted her life. And then we'll use this as sort of a launching off point to talk about how these medications work, when do people take them, what do they do, that type of thing. So 6 minutes, and then we'll come back together.
I just wonder if you could tell us about your life before treatment.
I started opiates when I was in college, and it was just, kind of like once a month use with a girlfriend, my roommate actually, and then we started doing it a lot more. But then we would stop, and all of a sudden, it's like we would have these withdrawal symptoms. At the time, we had no idea what withdrawals were, that we could become addicted to, our bodies would become addicted to something. I stopped for a couple years. I was still drinking, so I wasn't completely sober, but then I started back up again in my late 20s. I started using heroin probably 27 or 28. I mean, I was addicted full blown at that point. You're a slave to this drug that has completely taken over your life and you as a person. You're no longer, you're lying. I didn't know how to get help, and I didn't want it. I didn't know what my life would look like sober, and being an addict, period. It's like we're digging ourselves our own holes, because the shame and guilt for me personally was a lot of, well, I'm already lying, I'm already using, my friends already know, my family knows, like, I'm just gonna keep using to numb that, and it's just like this vicious cycle. I was getting down to my very last bit of heroin, and my mom had actually opened the door, and I was just out of it, but I was trying to shoot up, and she walked in, and it was like there was no hiding it. She already knew, but she didn't know to that extent. And I went to MOUD, I think it was 2 weeks or 3 weeks later, and I got in, and I had to go through detox again because I was under the influence. And once I got there, it was probably 2 weeks later where I was able to see a doctor to get on the Suboxone program.
So can you tell us then what it's like transitioning to Suboxone and how you feel on that and how your life is now?
The program, treatment, and Suboxone saved my life. I do feel like that is the truth, because I don't want to say it was just Suboxone or it was just treatment. Treatment gave me the tools and the resources in this area and within myself to be strong enough to overcome addiction and why I used. I wasn't sleeping. I was extremely uncomfortable in my own body, and it mellowed all of those withdrawals, but it also and I still wasn't comfortable. I still wanted to use when I was first taking Suboxone, even though my urges weren't as strong. So I look at my life now and then how it was before, and I have had someone who has said, you're basically just you're still using a substance, and I quickly was just like, yes, I am, but I'm also a completely different person than who I was when I was using. I would not work 7 days a week and have an animal that relies on me. I would not have strong relationships with my family, with my friends. So that it hurts when someone says something like that. But I also see where they're coming from, because it is something that I take every day. And and, you know, people can abuse it, and they do abuse it. I feel like if it's used properly, it can save a client's life, a patient's life, a person's life. I'm honest with my family. I'm truthful with myself, with therapy, with friends, with counselors, doctors. With Suboxone, you know, when you initially take it, it calms everything, and it clears your head, and it stops those withdrawals. And at that point, if you really do want help, that's what you want it for, is to get rid of the withdrawals, and so you can think and concentrate, and then you know, once you stay at treatment, or whether you're an outpatient or inpatient, you know, there's a lot of people there to help you and support you, and you get relationships back, and relationship with yourself back, and I think it helps. It definitely helps you do that.
Right. Pull the slides back up. Great. So that was Kat's story. And I think that is a similar story to what we hear from the folks that we serve that do get access to medications for opioid use disorder, and how they can help support them getting into other recovery services. And we'll talk about that in a bit. So you may have seen some sort of graphic about this. I mean, it's in the newspapers and on social media about how we have this overdose epidemic. I will say one thing from a language perspective: the more instead of opioid crisis or opioid epidemic, it really is an opioid overdose crisis or epidemic, right? Opioids in and of themselves aren't good or bad. They can be used for many useful purposes for people, but it's really this overdose that we're concerned about, and the harms from these overdoses. So we had in the late 90s that sort of first wave of these overdose deaths from prescription opioids. And then as we saw, you know, tightening up of those prescribing habits, as time went on, then folks started using more heroin, and we were seeing heroin overdoses around 2010. And now we're in the age of these synthetic opioid overdose deaths, like the fentanyl. You'll hear fentanyl or fentanyl analogs. And again, fentanyl is actually used every day in hospitals, you know, everywhere, safely, to help with pain and help with procedures. So it's not just the drug that's the problem. It's when it's a dose you don't know, or contaminated with other things that folks might get on the street, where it becomes a problem where they don't know the dose. So fentanyl in and of itself is not necessarily something to be afraid of, but fentanyl and its analogs in unknown quantities in the street supply of drugs is of concern, and is definitely what is causing the bulk of the overdose deaths that we're seeing. And just a reminder to myself and others that when we talk about these statistics and we talk about these huge numbers, that really it's like these are our neighbors and our family members and our friends that are experiencing this, and these are people that we care about. So what is opioid use disorder or opioid addiction? It's use of an opioid, and this could be, when I say opioid, it's really an umbrella term for any kind of opioid, a prescription, an illicitly manufactured, any of those are all opioids. They all work at the same receptors, some, you know, differently, but all opioids. So that could be heroin, fentanyl, prescription pain medications like oxycodone. But when it's a use disorder or an addiction, it's compulsive, dangerous, or both, and it is an illness, not a weakness or a moral failing, and can affect anyone. And when I'm talking about this, and we're talking about this with our folks we serve, we talk about it as sort of this chronic relapsing brain disease characterized by the 3 C's of craving, compulsive use, and use despite harmful consequences, right? So I think that's maybe the 3 C's are one way to describe it to people. And I think it's important also that we recognize this is sort of an you know, a non-nuanced oversimplification of this chronic relapsing brain disease model. And there are limitations to using that models, and it's sort of under discussion of if that is the best model, but we found it very useful in talking with people and destigmatizing what they're experiencing and helping them access the treatment we need, which is why I'm talking with you about it today. So thinking about it as a brain disease, just like you could have heart disease or lung disease, It's a brain disease with craving, compulsive use, and use despite harmful consequences. And another way that I like to explain this is that when we're talking about addiction, we're talking about chronic opioid use that develops into addiction, we're talking about sort of hijacking that biologic or reptile portion of the brain. And that's the part of your brain that's automatic. You can't think your way out of it. It just does its job. So that's the part that says you gotta breathe, you're thirsty, you gotta drink, that real drive that you don't think about, but that your body drives sort of on its own. And when you are addicted or to an opioid, that part of your brain really hijacks the thinking brain, right? That's why you have this compulsive use and use despite harmful consequences, because you can't think your way out of it, because your reptile brain is taking charge and like, hey, we're going to die if we're going to be in pain, and it's really going to be terrible if we don't use, right? So it's not the thinking brain anymore that is working. It's that reptile part of the brain that's causing that drive to use. And it's really not a simple cause. And I think if anybody either has personal experience or knows or works with folks with substance use, it does depend on the agent or the drug, right? When you think about an opioid versus a stimulant like methamphetamine, different types of nicotine, different drugs work in different ways and have different impacts in the body from each other. And then you think about the host, the individual person, right? What are their genetics? What are their pre-existing conditions? Who is this person? And then their environment. What's the context they're in? I think this is very important as well. And how does that impact addiction? So how those three things come together can be in any number of different ways for people. And it's really not a one size fits all for addiction or what will work for people for recovery. So I think that's important to know too. So besides the three C's we just talked about, two of the other diagnostic criteria for an opioid use disorder are tolerance and physical dependence. And I just want to be clear that these are expected. So if someone's chronically on an opioid, let's say for some sort of pain syndrome, maybe they're prescribed an opioid and they've been taking it a long time, they will develop over time tolerance and physical dependence. And that means tolerance is where you need like maybe 10 milligrams used to work to help your pain, but now you need 20, right? You need a higher dose to get the same effect because you've become tolerant. Your body has adjusted. Physical dependence, again, your body is adjusted where you can only function normally in the presence of the substance opioid, as we're talking about here. And these are expected. So these are part of the diagnostic criteria, but these two alone don't make a diagnosis. And I bring this up too, because once you become physically dependent, right, then your body only functions normally with the substance. And that becomes really important when we think about why we use medications for opioid use disorder. Here's sort of a back of the napkin diagram that I've used many times and really helped me when I was first learning about this. If you look here on the y-axis, this is how somebody feels. So dysphoric or bad, sad, kind of okay in the middle here, happy, and then euphoric or high, how you're feeling. And then as time goes by here on the x-axis. So for a healthy person, we have this normal variation in mood. We have our ups and downs, but kind of generally around that baseline, we get back to that baseline. For folks that use maybe intermittently, maybe their brain isn't susceptible to opioid addiction, maybe they get that euphoria or high, they get a little bit of a hangover or dip down, come back to baseline, can go days, weeks, months, no use again, kind of same thing happens. But if you have a brain susceptible to addiction and you're using a substance over time, and that how much time and how much you need to use is highly variable for people, but you'll use that first time and get that higher, that euphoria and the dip, but then subsequently over time, as you're using, that high becomes less and less, and that low becomes more and more, to the point where you are fully dependent on the substance. And if you're not using it, you're sitting all the way down in dysphoria, in withdrawal, feeling terrible. And like you heard Kat say in the video, the medication gets you out of withdrawal so you can think again, right? She just talked about like you're in withdrawal. That's your reptile brain, like craving, gotta use, gonna die if I don't use. And so I think it's important to know that over time, as the brain adapts to a chronic opioid use, and if one develops an addiction, they're sitting down here in withdrawal and dysphoria if they're not using. And at that point, they're using to feel normal, to function, to go to work, to take care of their family. Because when they're in withdrawal, how people feel from opioid withdrawal is pain, runny nose, watery eyes, sweating, diarrhea, vomiting, shivering, feeling incredibly irritable and restless, and, crawling out of their skin. And like people talk about with us, I feel sick, I feel vulnerable, scared, like I'm going to die, really terrible. And so they're using to get back up to that baseline and function normally. And are people using, some people still using to get the euphoria or get the high? Of course. But at a minimum, folks are trying to get back to just baseline functioning. And then I think another important point around this is once someone stops using a substance, depending on the substance, depending on the person, depending on how long they've used and other factors, it really can take quite a while to get back up to that baseline. And it's very variable by individual, but we're not talking like hours and days, right? We're talking like years to get back to normal in many cases. And I always like to think about this for myself too, like, would I stop? Would you stop using if you have like no enjoyment without the drug? You feel terrible without it. You only feel normal with it. You're like preoccupied and like compulsively using. It's just automatic and it's hard to break the cycle. You don't have great memory. Maybe you're emotionally all over the place, impulsive, vulnerable to stress. You really just feel hopeless and your life sucks. People tell me that life sucks. And if you use, you'll have that access to instant, reliable relief, even if it's temporary, right? You'll feel immediately better. And how my goal would be for us to make it a lot easier to get into recovery and get it access to medications for opioid use disorder, because right now we have so many barriers. So how do we make it as easy to get into recovery and get recovery support services and access to medications that are appropriate? How do we make that as easy as it is to get the drug on the street? Just want to reiterate dependence again with this graphic that we showed before. So, right, you get that euphoria, maybe a little bit of hangover and dip, but over time, if you're not using, you're in withdrawal, and the only way to get back to baseline is to use and get out of that withdrawal. And so I think that's important to understand as we talk about why would we use medications? Aren't we just substituting one thing for another, and have that discussion? So it is treatable. Opioid use disorder is treatable. I think that's awesome and important. And so medications for opioid use disorder or medication assisted treatment is really the use of approved medications plus counseling and behavioral therapies for a whole person approach. And there's no reason that you can't just start with the medication and then once things stabilize, get those counseling and behavioral therapies on board. There is evidence that medications alone have significantly impactful outcomes in improving overdose death. And so we'll talk a little bit more about that, but ideally it'd be this whole person approach to recovery. So here's sort of the money slide on, what is the data, what does the research say about why we use medications for opioid use disorder? And I'm specifically talking about methadone and then the buprenorphine products like Suboxone here. There's a third medication we'll talk a little bit about called naltrexone that works differently, and there's less data for its use, but it does have a place for some people. So why do we use these medications? Aren't we just substituting one thing for another? We sure are. And guess what? Guess what happens when we do that? We actually get people to reduce their opioid use. We reduce opioid-related overdose deaths, pretty important outcome. In addition to that, for the individuals, we also reduce criminal activity, right? So people aren't participating in criminal activity, maybe to get money, to support their habit, et cetera. So that's an important community outcome. Reduces infectious disease transmission. This is huge, right? Because people, especially if they're injecting, are at risk of HIV, hepatitis C, other types of infections from non-sterile equipment. And so those can cause a lot of damage for people, and they can cost a lot for the system as well to treat if someone needs a heart valve replaced or they need medications to treat their HIV or hepatitis C. And if we can reduce that, then we can have better quality of life and certainly reduce expenses. So it does save money. So there is a return on investment for providing access to medications for opioid use disorder for people. And that's all well for the individual. They also have improved social functioning and retention and treatment and ability to access other services that are helpful to their quality of life. So this is all known as like a harm reduction strategy, which really, again, I wonder if that's stigmatizing because all of medicine is really harm reduction. How do we help people have the best quality of life for whatever conditions they're treating? And opioid use disorder is similar to that as well. So reduce use, reduce death, criminal activity, infectious disease, and save money while the individual gets better quality of life. So pretty compelling data over decades for methadone and buprenorphine. Harm reduction, there's a resource there, harmreduction.org. It just really works to minimize harmful effects rather than ignoring or condemning them. So are we just substituting one thing for another? We sure are. But saying that to people, as you heard Kat say, can be really hurtful, and saying they're not in recovery because they're taking a medication is hurtful for them. And I don't think that's our intention. Would it be ideal if nobody needed a medication? Well, of course, that would be great, but that doesn't work for everybody. And if it helps them be alive and contribute and have a quality of life, I think that's a really important thing to consider. So it's a harm reduction strategy. They're taking a medication, but they know what the medication is. They know what the dose is, right? Versus if they're buying and using off the street, maybe they think they're getting, some OxyContin or some heroin, and it ends up being some fentanyl analog, and then they overdose or die or have other complications from that. Just a reminder that opioid use disorder is not a choice or moral failing. It's a chronic relapsing condition that's a response to physiologic changes in the brain that is treatable, often long-term, and can happen to anyone. And I do want to talk a little bit about relapse, and that's not necessarily the most person-first language, but that's why I put it in quotes. But return to use or recurrence. When we think about having a chronic condition, not being at goal 100% of the time is expected. And when we look at addiction versus like diabetes or hypertension or high blood pressure or asthma, the rates are actually pretty similar. And I think diabetes can be a really good reframing. And it's always helpful to me to check my own bias as well. So like when we think about somebody, if you know anybody with diabetes, right, they have high blood sugars. Sometimes they have to take injection medications or oral medications. They have to maybe check their sugars and go into the doctor more frequently. Maybe they have to meet with a dietitian. Maybe it's the holidays and they are just sick and tired of all this like sugar checking, and maybe they just haven't been taking their insulin all the time because they're just tired of doing it or have other priorities, or maybe they couldn't afford their insulin for any number of reasons. It's the holidays, they're stressed, maybe they're eating more cookies than usual. And when they come into to see their doctor doesn't say, shame on you, you're not at goal, so I'm not going to prescribe you insulin and good luck. No, right? We meet someone where they are, like, what's going on? What's going on in your life? What's the context? What support do you need? Do we need to adjust your medication? Do we need to adjust your monitoring? Could it be helpful to meet with a therapist or a dietitian, et cetera? So we meet them where they are and then help them from there. And so I think it just is a helpful reframing to remember that people aren't always meeting all of their goals with their other conditions as well. And addiction is no different. And the other part of it is, you don't expect that, like, let's say you're diagnosed with diabetes and we give you medication. We don't just say, okay, here's your med, have a nice life, right? We follow up. It's treatment over time. And let's say you're really stable. Maybe you even manage it with your diet and exercise and you don't need a medication. Maybe we just see you every 6 months to check in, right? Or maybe you're not quite at goal and things aren't going great, and maybe we check in with you every 3 months or even every week, depending on what's going on. And addiction is the same. So maybe somebody in the beginning needs more supports or different types of supports, and over time that changes, but we never just send them off on their own and expect it to be fixed after one episode. So I think one thing I hear is people are like, they're in treatment again. Right. Yeah, it happens. The return to use is expected at times in folks that are working on recovery. And so I think thinking about it, like we think about supporting people with high blood pressure or diabetes or whatever it is that they have over time with different intensities as they need it, is a helpful framing of that as well. Just briefly, I won't get into all the pharmacology of how these medications work, but opioid receptors are in a variety of places in the body, and specifically in the brain is what we're talking about with addiction. And so we have these opioid receptors. Here's the graphic here. And the medications sit on that receptor and have activity. So methadone as a treatment, as an opioid use disorder treatment, is an opioid, and it's what we call a full agonist or full activity. So when that goes onto that receptor, it has full activity on the receptor. And that's why people can go from using opioids to methadone directly, because it will sit on there and it will help keep people out of withdrawal. immediately. And the difference between that and then the buprenorphine, which are like the Suboxone, you might be familiar with that brand name product, is it's a partial agonist or has partial activity. So why is that important? It's super important because if someone's been using fentanyl or Lortab or something and they've had that full effect on here, like a full agonist, and then you put a partial, it's like going from instead of easing off the gas when you're going 60 miles an hour, it's like braking and stopping and flipping them into what we call precipitated withdrawal. So if they're getting full activity and then all of a sudden that gets moved to partial activity really quickly, they can go into precipitated withdrawal. So people will need to get into withdrawal first, and then we start the Suboxone. And that can take anywhere from, it may take them 6, 12, 36, 72 hours. It really depends on the substances they've been using, how long it will take them to get into withdrawal enough that we feel comfortable starting that buprenorphine to help, again, stabilize, pull them out of withdrawal, but not cause what we call precipitated withdrawal. So you may hear people who weren't had too much of their opioid on board when they started their buprenorphine. And so they'll say, oh, it made me sick. Well, yeah, it may have put them in withdrawal, which makes them feel sick. So we always want to be really mindful of the timing of that and doing it with good supervision so people know. And interestingly, some people just know their doses. Maybe they've bought buprenorphine on the street and they know what works and what doesn't work for them once they get plugged into care because they've figured that out on their own. But ideally, we would have access and be able to advise folks on the appropriate dosing. Naltrexone works the opposite way, which is it sits on that receptor and it blocks it, which can help with cravings. And then if you use opioids, they don't have effect, right? Because that's sitting on there blocking that receptor. So for people who maybe don't want to use an opioid for their treatment or can't for some reason, they could go completely through withdrawal with other supportive mechanisms. And once they have no opioids, usually about 2 weeks, they could start the naltrexone. You may have heard of the once a month injection, Vivitrol is what naltrexone is. It's an option. There's less data to support its effectiveness for opioid use disorder. So again, why do we use this? Because remember, as people use over time and they've become dependent, they're in withdrawal, and to get them back to baseline and prevent their use, we give them the medication for opioid use disorder, get them back to baseline. And it's kind of like thinking about the reptile brain. It like settles down the reptile brain so the thinking brain can participate and engage in other forms of treatment. Dr. Heather Bell is a family medicine physician in Minnesota. And this is just a quote from her, but we tell patients this medication, it's your insulin, it's your blood pressure med, it's helping your brain function, really trying to destigmatize medications that we know are effective for people with this condition. These are quotes from where I work, folks that we serve at the Center for Alcohol and Drug Treatment here in Duluth. My son got his mom back. I haven't gone back to jail. I can pay my bills. I'm going to school. I have a home, a vehicle, a bank account. And so, just it's amazing to see how revolutionary this can be for people to get into recovery and really have an improved quality of life and improved relationships like you heard Kat talk about in the video. All right, that was a lot of words. We're at 12:35, so we're in good shape. I have a few polls, but before I get into that, does anybody have any questions you want to chat in or unmute? All right, I'll keep an eye on the chat and we'll get to it at the end if we don't get to it now. So I'm going to run through these 3 polls and then we'll talk about them. So again, the actual polling mechanism isn't set up today, but we can use the chat. And if you're not comfortable using the chat, you can just think about it. All right, so the first one, medications for opioid use disorder should be offered to pregnant individuals with opioid use disorder. Of course they should. B, I'm not sure, or C, that's a terrible idea. Why would we ever give a pregnant person medication for opioid use disorder? So if you are comfortable, if you want to chat in what your thoughts are on that. All right, seeing a variety of responses, seeing mostly A's and B's, and maybe there's some C's out there, but maybe they're not sure they want to share that. All right, we'll go on to the next one and then we'll come back to these. So babies born from individuals taking medications for opioid use disorder are born addicted. So if someone has a baby and they've been using a medication for opioid use disorder like methadone or buprenorphine, is the baby born addicted? Yes, no, or I don't know. All right. We're all across the board on this one, which is very much expected. All right, so we'll come back to that one. And then finally, individuals should taper off medication for opioid use disorder like methadone or buprenorphine within 3 months, 12 months, 24 months, or never. What are your thoughts about that one? All right, seeing quite a few B's and C's, and then Alyssa with E and her individualize it. All right, I like it, going off script for your answer. Thank you for your engagement in this part. So let's talk about these things. Let's start off with pregnancy. Can we use it in pregnancy? And the answer is absolutely yes, yes, yes. There are benefits for mom and for the fetus, reducing overdose, death, right? Decreasing risk of infections and increasing engagement in prenatal care and recovery treatment, as well as reducing sort of those highs and lows and fetal stress that can be caused by non-prescribed use, and decreases loss of the fetus and preterm delivery. So it is an absolutely great time to engage mom in treatment and be supportive and help her get what she needs to be safe during the pregnancy and deliver as well, and give that baby the best chance of a healthy delivery as well. So yes, absolutely should be used. All right, and then the next question was around, are babies born addicted? And this is really important, and here's a key takeaway you can share from this. Babies can be born dependent and have some withdrawal symptoms, but they are not addicted. Remember, they're not compulsively using despite harmful consequences. They're dependent. So I just want to, let's remove the addicted baby from our anything we ever say in the future, and just remember these babies are dependent. They can have some withdrawal at birth, and that's very manageable, right? So some of the things that can be done are things that any infant, I think, would like, which are, rooming in with the mom, quiet, calm environment, skin to skin, breastfeeding. And then if the baby's really having some withdrawal that's impacting their sleep and eating, they can give the baby methadone or morphine short term to help them get through that withdrawal. And that can be done completely safely for the babies as well. So they can be born dependent, but they're not addicted. And I think another thing that comes up is, women who are pregnant and using or have used or are using medications for opioid use disorder have a lot of, in my experience, they are experiencing a lot of shame and stigma. And I think as much as we, as whatever it is your job is, if it's in community or in healthcare, as much as we can be supportive and encouraging, that can be really helpful and go a long way. And another thing I hear from pregnant folks is that they think if they reduce their dose of their buprenorphine or reduce their dose of their methadone, that their baby will be less likely to have dependence or withdrawal. And that's not actually true. That's not true, right? And there's not a direct relationship between the dose and whether or not the baby has withdrawal or how bad it is. So the best dose for the mom or the pregnant individual is the dose that keeps them stable in their recovery and not using other opioids. The mom needs best. In fact, for folks in pregnancy often need their methadone dose increased, and sometimes they need to split their doses to get the 24-hour coverage because of the changes that happen to the body during pregnancy. The babies that can be dependent, they're not addicted, and the best dose of methadone or buprenorphine for mom is the one that keeps her stable. All right, and should people taper off? Not the goal. So I know there are programs that have specific timeframes and things, but those are not evidence-based. There isn't a specific time. And it may be that someone is best served by being on that medication their entire life, if it keeps them stable and keeps them with their quality of life. And I know some people have a variety of different viewpoints about chronic use of medications. Different cultures have different thoughts about that and beliefs about that. And people sometimes want to come off like, I just don't want to have to take this med. Or if they're on methadone, I mean, it's really hard to get. You have to like go to a specific clinic. And in northeastern Minnesota, we're like the only one for hours away. So some people travel really, it's a hassle, right, for people to get it. So maybe some of those factors are part of why they may want to taper or go off the medication, which is their choice and they can be supported. But I think it's really important that setting an artificial deadline is not person-centered and it's not evidence-based. So the research doesn't support that. It really is individualized, as our colleague mentioned in the chat, of what that person needs and for how long. So I think that's important to remember, because I think sometimes you think, well, we're going to be on this forever. Isn't just, substituting one thing for another. It absolutely is, with really good benefits. I think another thing that comes up sometimes is like, well, what about people abusing or misusing their medications? And does it happen? Yes, it does happen. There can be diversion where somebody sells or gives their medication to somebody else. And it's hard to really quantify how much of that happens. But what we hear from people is it really is like, my partner, my sister, whoever, they were in withdrawal. So I gave them half my dose to help them not be in withdrawal because they weren't able to get into the doctor or they're too afraid to go in or whatever it is. So a lot of the diversion anecdotally is really to help others not be in withdrawal and really altruistic. And there are a lot of strategies to minimize misuse, and that you can limit the amount that's prescribed at a time that someone can take home. You can have them bring in their bottle pills or films, whatever the formulation is, like to, unannounced, like, hey, bring in what you have left to make sure they have the right amount and they're not, selling it or using more than they are prescribed. And then certainly urine drug screens to make sure they're actually taking the medication. One other thing that I think is a misconception is, like, let's say somebody is being treated for their opioid use disorder, but then they're using methamphetamine or cocaine or something else. Can you still treat their opioid use disorder with medication? And the answer is yes. Just like we wouldn't stop treating your hypertension because you have diabetes, we're not going to not treat your opioid use disorder because you have a different substance use disorder. And it's very common for people to have more than one substance use disorder. So treating their opioid use disorder allows you the access to them to work with them on potentially supporting their recovery or treatment of other use disorders as well. So I think that's important to remember. We do need to be careful with some things like alcohol and benzodiazepines, as an example, if they are taking buprenorphine or methadone, because that can increase their risk of overdose and cause some, because of the drug interactions. We need to be mindful of that, and we want to be safe with people. But just because they're using some other substance doesn't mean we cut them off from their opioid use disorder treatment, right? That would be kind of counterproductive. So I think that's something people often have questions about. I always want to put a plug in for naloxone, or one of the products is Narcan, you may have heard of, and making sure that everybody who has an opioid use disorder or is at risk of overdose has it available to them and their nearby loved ones. This is a medication that reverses an opioid overdose. So when you get too much of an opioid, what happens is you stop breathing, your breathing shallows and you stop breathing, and then your heart stops. So what it does is it kicks that opioid off that opioid receptor in the brain, like we talked about, and actually puts them into withdrawal, right? But helps them breathe again so that they are alive. And that's really what the goal is. It does not enable use. People don't say, oh, I have Narcan, so now I'm going to use. Like, they're going to use. Narcan's just going to save them if they use too much, or their friend or partner used too much, as an example. So very important that we have this available. It comes in a nasal spray or an injectable, and it reverses opioid overdoses. The standard doses that are available right now are sufficient. There's some different higher dose formulations and things coming out, but it's really questionable whether that's necessary. It is important to know, though, that some people may need more than one dose. So they need one, they get their dose, their overdose is reversed, but they still have some of the opioid in their body, and maybe it goes back on the receptors, and then they need an additional dose after that. So it's important, if people do have an overdose, that they get medical attention. And I know a lot of our folks are afraid to call for medical support or call 911 because they're concerned that they'll get in trouble. And so I think it's really important that we provide education about that as well, to help people be safe. The other thing about this too is you might hear like, well, I gave them naloxone and reverse their overdose, and then they just went and used again. And people take it personally, like, I just saved you, now you're using. Well, what happens when we give someone naloxone is we put them in precipitated withdrawal. We basically flipped their reptile brain back on real quickly, saying, if you don't use this substance, you're gonna die, right? They're in withdrawal right away. So it's not surprising that someone gets an overdose reverse and then they like head out of the emergency room and immediately go use. And that's why we'd like to stop that cycle by offering them access to opioid use disorder treatment, including medications like methadone or buprenorphine, so they can get out of withdrawal, settle down that reptile brain, and then allow the thinking brain to help them decide what they want to do next and see if they want to engage in other recovery supports for their opioid use disorder. Stigma is huge, right? We've surveyed and talked with folks with use disorders, and this is the number one barrier for them in biomedical care and treatment care and life. I mean, they're stigmatized in multiple realms of life. So I think one of the ways we all can help destigmatize is to really know the facts and really understand that, why do we use these medications for opioid use disorder? Well, because it reduces death, crime, infectious disease, it saves us money and helps people have better quality of life, harm reduction, and it works. And so I think if we know that, so we can sort of demystify and myth bust for people, it can help provide an environment where people feel more comfortable talking about their use disorder or maybe accessing treatment that would be helpful to them. So I hope that this is a big takeaway for you, that these are the reasons we use these medications. And so you would be able to educate others about that. Also, this is from the Institute for Healthcare Improvement. This Recovering Hope and Stop Talking Dirty. So this goes back to being mindful of the language that we're using with people and not talking about, junkies or addicts. People can refer to themselves however they want, but that we would talk about, an individual with a substance use issue, and just be mindful. And this language is consistently evolving. So some of this might even be changing as well. So just being mindful and aware of how we're speaking and how that can impact people. So I'm curious what your ideas are for reducing stigma and what questions you have or experiences you have or anything that I said that you disagree with. So what I'm going to do now is go ahead and stop the recording. Thanks for everyone for joining. And then